Hi, everyone. My name is Nicole White, and I'm the Executive Director of Rare New England. Welcome to our annual virtual conference, Learning from Each Other. Thank you to everyone for joining us, and thank you to our sponsors. Our platinum level sponsors are Ultragenics, Horizon, and Vertex. We have gold level sponsors, which is Grail. And our silver level sponsors are Homology Medicines and Stealth Biotherapeutics. I'll hand it over to our moderator, Dr. Corson.
Thank you. I'm Mark Corson, and the way the webinar is structured tonight, I would ask that please keep all speakers and attendees, please mute your microphone, and only if when speaking, turn it on. Attendees, we invite you to submit questions. Please write them in the Q&A box and not the chat box. That's where we're going to look. And I think that's about it. We certainly want your feedback afterwards. Let us know if what you liked, what we could do better. And thank you for coming.
Also known as CF, is a great example. The gene that causes CF was discovered over 30 years ago. Its mutation led to problems with the CFTR protein, and no one thought it could be repaired. But for years, we persisted, and today our scientists have produced medicines with the potential to help up to 90% of people with CF. Now we're applying what we've learned to tackle other diseases and to continue to discover medicines to potentially help the less than 10% of people with CF who don't make any CFTR protein. We're exploring exciting new technologies like gene therapy, gene editing, RNA therapeutics, and cell therapies. These approaches should help us get to the roots of serious diseases that have few, if any, effective treatments today by addressing their underlying cause. We know from experience that by choosing the right problems and being creative about how we tackle them, we have the potential to make scientific breakthroughs that may change the course of diseases for patients and their families.
Mark, I think you're muted.
Yes, I am. So I'm following instructions. All right. So tonight's topic is challenges and successes in today's healthcare system. So this is an opportunity to offer patients and families not only information about the disease, future expectations, and possible impact on the family, but also guidance regarding an expanding array of treatment options. That is the plus side of this medical system that we have here in this country. But the flip side is that the healthcare system is becoming ever more complex. There's too much. There's too much of everything: tests, treatments, regulations, protocols, egos. Medicine has become super specialized. Few doctors know the whole patient anymore. And if they do, they don't know all the ways the system and the patient can interact. The net result? Patients can easily feel isolated and helpless. especially if it's up to them to take the lead and navigate the medicine jungle. It's not much easier for healthcare providers either. They are being dwarfed over time by the ever-growing, ever-complicating medicine elephant. Help. So tonight we're going to hear from three speakers. Actually, we're going to hear from three speakers. One patient advocate par excellence, and two geneticists from different major medical centers in New England. So let me just introduce myself formally. I'm Mark Horson. I'm a geneticist, and I work with VMP Genetics. I am pioneering a different type of medical practice, a physician support service, recognizing the genetic, the workforce shortage in this field of medicine. And I also direct educational services at VMP Genetics. Christine von Reisfeld.
Sure. Hi, my name is Christine von Reisfeld. I am a rare disease and autoimmune patient. Mark and Michelle and Tanika, I appreciate everything that you do. I have found the precision medicine aspect of care to be something that has helped me alone. And so I'm really on my own diagnostic journey and hoping that what I learn can help other people in really learning what to ask for and learning how to form those relationships with their healthcare providers to really get the best and effective or most effective quality of life and care. So I'll leave it at that because I could go on for hours, but I don't want to take up that much time.
Welcome. Dr. Tanika Fornfukel.
Good evening. I'm Tanika Ponpatkun. I'm also a medical geneticist. I work here at Hasbro Children's Hospital in Rhode Island. I've been taking care of children with various metabolic conditions for the past 20 years. Thank you.
Thank you. And Dr. Michelle Spencer-Manson.
So yeah, I'm Michelle Spencer-Manson. It's nice to be able to be here and talk, and thank you everybody for joining us tonight. So I'm also a clinical geneticist. I've been at Yale for about a decade now. Before that was at Duke, so kind of done both parts of the Eastern Seaboard. So I have I'd say about 50% of my practice is inborn errors of metabolism. The other things that I kind of work on is I do a lot of stuff with neurogenetics, neuromuscular, and congenital disorders of gastrointestinal malformation. So I kind of have a couple different things. Most of my research is in neuromuscular, metabolic disease, and GI malformation. So thank you for having me.
Welcome, speakers. It's great to have you, and you're coming at this from different perspectives, and that's terrific. So let's begin with some questions. And again, audience, feel free as questions come to mind, again, put them in the Q&A box. So panelists, COVID-19, a pandemic, really confronted our healthcare system. How do you think that COVID-19 has impacted healthcare and the patient experience? And there's going to be a positive and negative. So let's start with the positive. How is it positively impacted? Let's start with Christine.
Sure. So we're sticking with positive?
For now. We'll get to the negatives. You're muted. Yes. Can you unmute your microphone?
Oh, I was muted. I'm sorry. And so we're going with positive. You can hear me, right?
Yes, thank you.
Perfect. I would say the one positive thing that I think has come from COVID is really an awareness, a different sort of awareness around healthcare. I think that illness, mental health, all of these issues that some of us, especially autoimmune or rare disease patients, has always kind of gone unnoticed. And I think when our general population got sick, unfortunately to say, but I think that really spurred more of the conversation around health. And the other positive that I've seen is really some of the collaborations that have come about. You know, I think that we have done things during the pandemic that we never thought would have been possible, but because of the situation, we had to. And so for me, it just gives me hope that we were able to do this. There are ways that we'll be able to work through everything else with that collaboration. And so those are my positives. I'll hold for the negatives.
Okay. Michelle, what do you think? Please unmute. Yeah.
So I would say the biggest positive thing that came out of COVID was our ability to deliver care in multiple modalities. And I would say telehealth. And I would bet Shanika will probably say something similar. So I'm glad I got to go first. But I mean, the pivoting to telehealth has really revolutionized, particularly for the rare, I think particularly patients with rare diseases that are oftentimes medically very fragile and very complex. Instead of canceling appointments with me now, if they're sick and they can't come in, or there's transportation issues, whatever it is, we can, we can pivot to telehealth. And the other thing I think that a lot of times, when people get new diagnoses, I've also found, we have a conversation, we go through the results, but like 3 or 4 days later, they have a ton of questions after they've done their own research. And it's more than we can do in a phone call, but less than really we want to have them come all the way back into the office. And so we can spend time and have a really meaningful face-to-face conversation with that. So I think that's there. And I would agree actually with what Christina said too, is that the other thing is I do think it has made us be more collaborative as practitioners, because we had to, and some of us even, went back and we got pulled to do medicine and stuff we hadn't done before, but we were there backing up our internal medicine, our pediatric colleagues when they were overwhelmed with patients, doing what we can. And I think it maybe brought some of us back to that kind of what I'm going to call our cornerstone, right? All young medical students go into medical school, we're going to help people, right? And then, the realities of paperwork and stuff sometimes kicks in. And I think their sense of just community building, of just focusing on taking care of the patient, I think really kind of came back in the center for a lot of us during the intensity of the pandemic.
Shanika, what's your perspective?
Well, I can't be more agreeable to what Michelle just said. I think pivoted to telehealth was one of the best thing we have, and we continue to use that for our patients. And we have been able to be creative. For example, we really need that weight, and so just use your scale, like at home. The other thing that I found, and this is pandemic, which resulted in, supply chain, the collaboration between clinics, between regional, between families, you running low on this formula, who else has it? And I think between the use of telehealth, the use of social media and network, this has allowed us to serve our patients. So I thought those are some of the positives. And I think for our established patients, we do want to see them, but we don't need to see them in person at all visits. So that's definitely a big plus. And I agree with Michelle. I had a very complex patient, and for the first time, we were able to have a consultation with the NIH at the same time, with the family, with the transplant team at Boston Children's. So it's like, you can actually make this happen. So that's what I really take it from, thank goodness, Zoom.
All right. So positives. So medicine went through a revolution, and it rose to meet the challenge in many ways. Different modalities of care, networking, bringing community together. What was the downside? What did COVID-19? How did it impact in a negative way? Michelle, do you want to give a thought?
Yeah, I think I had kind of a unique perspective on this because my husband is an inpatient hospitalist, so was on the front lines of COVID from the entire time. And I think, it really ripped off the Band-Aid of what is the problems with the healthcare system, right? We were not prepared for this. I think we've learned a lot and gotten better, but I think we overstressed the system, right? And I think that was there. And I think this is what COVID-19 has taught us, because although I think this was a negative, a lot of people didn't get their surgeries and didn't get their other stuff. And a lot of healthcare providers died during COVID-19 too. So I think we should remember the things they did there, and the patients and so many people. We lost so much life during this pandemic. But I think it's time for us to rethink about how we make sure we have capacity, how we make sure we have flexibility within the healthcare system, and how we make sure we're looking at ways to protect our patients and public health things. Because I think everybody else will say here, we have had some very really almost shocking conversations in societally about public health and whose responsibility it is for public health. And you've seen cultural differences between different countries, even within Western countries, how Europe and the United States and even different parts of the United States handled it. I think it's time to kind of look at some of these things of how do we make the system so it's flexible for these things, and how do we help? I think we already are in an overburdened healthcare system. How do we get high quality healthcare for everybody without having, you know, things that are persisting today, 6 hours, 6, 8, 10-hour waits in the emergency room and stuff. We have to increase capacity as we've increased need. And I think COVID really kind of brought that up in a new way. And then I think also just supply chains, right? I think this was, Shanika brought this up. And I think, you know, yes, we've learned to collaborate, but we've also, I mean, there's also been times we just couldn't get things for people. And we've seen this a number of times throughout the pandemic. And we really need to work on infrastructures and having meaningful conversations about what public health means.
Thank you. Shanika.
Well, the downside, as Michelle highlighted, I think in addition to, you know, the burden, the stress on the healthcare system is also the stress on the family. I think I've had a number of family who, you know, because we did not know what was COVID, had to like pull out their kids from school after the school reopened, but for, you know, an extended period of time, have a lot of uncertainties about sending the children back to school. As a result, is there, you know, long-term implication of that on the children or not? The other thing that I found in our population is the access to other services. For example, getting physical therapy, getting occupational therapy, getting speech therapy, that's been a real challenge. Not only just medical care, like for illnesses. So those are the things that I've thought, you know, and mental health support for family, especially for family that have children with autism or you know, behavior challenges, having to be in the home, you know, 24/7 for weeks and weeks and even months, really poses the challenges to the family. And there's not enough psych or psychologist support for those family or anyone at this point. Thank you.
No, absolutely. I mean, parents were employees at their jobs. They were parents, mothers and fathers. They were teachers. They were therapists. They were, you know, primary care providers, if you will, in the house. It was an unimaginable burden. Christine, what's your view on what went wrong?
On the negatives. So I'm going to give you, I'm probably going to be an unpopular opinion on this panel right here, but telehealth, right? I think it was amazing the fact that we could get telehealth together, but I also feel like that me as a rare disease and autoimmune patient also lost a lot of my care and access to my doctors. And so things that I have some conditions, right, where my doctor needs to touch me and feel me and see me, and they can't get that on the quality of phone that maybe I have, or the computer, or the connection even, right? And so I think, well, it's great that we have this as an option. I think the idea of COVID also pushed this idea that technology would be able to solve everything. And so I see one of the other negatives that I see is really that financial interest from companies outside of healthcare that are trying to get into healthcare. And so I don't want to harp on all of the negatives, but I think we need to really look at how we combine tech and healthcare in the most empathetic way, and still without forgetting about those patients of us who virtual is great for certain appointments, but for other ones still need to maintain that relationship with our physician. And I think that was kind of lacking during COVID, is building on that relationship with my physicians, right? I have great relationships with them, but with the surge of other patients and everything happening, I don't get that time anymore. And so that's one of the negatives, I would say, besides the mental health strain that this has caused on every single one of us. I would say those are my biggest concerns, is just that push for tech. And I'm done.
Yes, no, thank you. Absolutely. I mean, how many of us in a specialty clinic while doing our exams picked up something that is outside of our, specialty, and we picked up an ear infection, or we picked up a big spleen that we didn't anticipate that may be completely unrelated, and that help facilitates care that is absent if patients are only being evaluated by telehealth. So, you're struggling with not having the same relationship with your providers. Christine, tell us something about the challenges that you have with a complex disease in the healthcare system. So backing up not just COVID, but in general, now the system we're encountering. Yeah.
Oh yeah, definitely. So I have multiple conditions, and my care is not easy. I have a coordinated care team that we have brought in. We've brought in consultants, medical consultants, to really talk about my care. And I think one of the difficulties is as a rare autoimmune patient, I don't really look sick. And in the beginning of the pandemic in 2020, I actually went into heart failure. And the way that we found it, though, I had 8 ER visits and 15 telehealth visits. And it was finally at the last ER visit where I said I wanted a Holter monitor or something. I said, these things are happening when I am at home. My heart rate is low while I'm in the hospital, but you're saying it's a low normal. I'm experiencing something completely different, right? And so the technology in that sense really did help me of having that Zio patch available. But again, overwhelmed hospitals. I wasn't able to get in. It was ER visit after ER, and then telehealth, where they weren't able to monitor my vitals even through a telehealth. And so one of my biggest with managing multiple conditions is we don't really know on a video what's affecting me. There's no way to really look at me as an individual over a camera. And so I think I've struggled, right? I've struggled because my quality of care has gone down. My doctors are overwhelmed. My neurologists now have a new slew of patients, right, who have developed long haul COVID that are now taking up time for other physicians. And we don't have enough neurologists either. And so I think it's just kind of this overwhelming, everything's hitting at once. And when you're dealing with multiple conditions, when you're dealing with rare diagnoses where you don't have those answers yet, it becomes even more difficult to find them.
Absolutely. And let me go back and ask you to explain. You mentioned something about managing your illness. Are you the one managing your illness?
I've always been the one managing my illness because I'm so complicated. So I have a series of 1 million different specialists who all look at things from their very siloed area. And I haven't really gotten a holistic view of myself, right? And so I do currently manage my care, although after my last diagnosis, we have employed a coordinated care team. So now at my arsenal, I have a physician, I have my internist, I have a researcher on my team, I have a pharmacist, I have everybody that is needed in care. But the thing that I always wonder is, it's hard to manage one condition or two. I'm at 30, over 30 now. But in dealing with that, why does it take so long for us to get that option of coordinated care? And so it's hard, right? Trying to deal with these things when you don't know what's going on, and trying to portray them to physicians so that they understand you is extremely difficult. And that communication really has been lost.
Wow. Michelle, consider the patient with a lysosomal storage disease, multiple systems affected, or a patient with an organic acidemia, multiple complications. What do you see as what are the challenges that you see in getting your in getting your patient to navigate that the healthcare system?
I think there's a lot of things similar to what Christina has kind of brought up. I mean, I think you end up with a team of 6 or 7 doctors, right? For all these patients. They need the cardiologist, they need the pulmonologist, they need they need the hepatologist, or they need, and then they have like some of them even GI, some of them have like hepatologists and a dysmotility doctor, and so you have all these people. I would say, and I hope this is not going to come across as arrogant. I think for genetics, patients are a little bit at an advantage because I always say geneticists are the what do you call it? We're the generalist subspecialists, right? Like genetics is always, like every one of my notes has like every system and who they're seeing, what they're doing. We do a lot of that coordination and care of genetics. I think though I think we're kind of lucky in the fact, and I don't know how much longer this is lasting because I feel like every year they up my RVU goals. But internists are seeing 30 patients a day. They do not have the half an hour that I have to go through the entire chart and make sure like they're there and they have missed this appointment, they coordinate that. And so I feel like that's the least I can do is to make sure, and I'm always, even our best parents, where I'm saying like, you missed this appointment, showed, I know you didn't mean to, and that was there, but it's that. And then it's like, it's very hard for these families to go to work, right? So you have to, if you are doing 1 or 2 doctor's appointments a month, plus then you have to take time off because if the home health nurse doesn't come, or this doesn't happen, or that doesn't happen. I mean, it's like for the families, even with as much help as I think we give in genetics, and I think we have, because we have longer appointment times and lower patient loads, and because of rare disease, if you don't do that, nothing happens. We're not driving the patients to their appointments. We're not taking care of them at home. And it is another full-time job, right? And a lot of these families still have to work and have other children to take care of or other things they have to do. I just am in awe most of the time of what a rock star job most of these families do of learning highly complicated medical stuff, become advocates for their family members, for themselves, and then balance it with the fact that this is like having a second full-time job within their already complicated lives.
Yeah. Shanika, again, the multi-system affected patient. Sometimes with more than one affected person in the family. So complex. What do you see as any other challenges that you see that these families face?
So I do have multiple families with multiple children with the same condition, but each one of them are unique in their own ways and have different needs. And I think I like what Michelle was saying, that it's amazing how the family try to keep everything straight for their kids. For example, the lysosomal storage, it's not uncommon to have siblings with certain conditions, and both of them are on enzyme replacement therapy, and they need to be on enzyme. Can you get the enzyme infusion on the same day? But then there's school activity that happens, and then there's a asynchronous of the enzyme replacement therapy, and how do you get the home nurse and all that. So I think the multi-system organ disorders is very, very challenging. And I hear what Christine is sharing with us. And while I say that telehealth was great, I think I want to point out that in many places, we pivoted back to in-person very shortly. So I think this is regional institution says we pivoted back to telehealth. So the pandemic was mid-March when we shut down, and we were back seeing patients fully in person by the end of May. And telehealth was an option available for family who don't feel comfortable or whatever. But at this point, I think at least for the majority of our patients, it's in person with an option for telehealth. So I just want, yes, I love telehealth, but I do agree with you that there are a lot of things that get lost over the screen. And as a pediatrician, I see a lot of children with developmental disorders, and the best exam is actually observing the child in the room, playing in the room. That's actually our exam. Or
Mhm.
looking at this morphology. I can't do it in a 2D. It takes a little while for me. With the mask, it's a little bit much harder. So
Yes. Wow. Well, so you've talked about um, the roles of the patient and the provider in complex care. What's the role of the primary care provider? Is there a role, Christine? Or is there a role?
Well, I think there is a role for a primary care, but I think we need more primary cares who are actively involved, right? I have a primary care myself, and I'm not going to, but when I had to move to a coordinated care team, right?
Yeah.
And so my primary care wasn't able to handle all of these other doctors. And so we had to bring in another team. And then this team does have a geneticist on it. But I wanted to mention one thing really quick when we were talking about the family, because there's also issues, with rare disease. I have a genetic heart condition, and I've also come across family members who don't want to know. And so, that's been a struggle too, is really convincing my parents to be able to do this, convincing brothers and sisters that they need to look proactively at their care as well. And so that's become a huge obstacle as well. I mean, I know that we all talk about how with pediatrics, the families are a lot more supportive and you have that dynamic. But I think as we get older, we kind of forget more about that family dynamic. And so I would like to kind of just touch on that as we explore genetics, we also have to think about the people who don't want to know, and how do we approach them when we know that there is a condition that you potentially have something that can help them, but they don't even want to admit that they're sick. And so I think the genetics part of it also brings up a whole nother level, right? When we're looking at one sick patient, if it is genetic, it probably affects someone or multiple people in their family as well. So I just wanted to touch on that. But my primary, I think there is a huge role for a primary if that primary can really organize. I used to have a doctor that had meetings with my other doctors when I was, when I was in my 20s, and she would sit everybody down at a table and talk. And those conversations don't happen anymore. Now it's an email that goes from my primary to this department, and that department telling me, sorry, not my issue. And so I think a primary care's role should be more of that coordinated. But I think a primary is essential. I think you need to have a primary who oversees the whole system and then is able to coordinate with each of those physicians. But some are just so overwhelmed that you can't do that. So that's my role on the primary.
All right. So there are two points here that I
There were
want
2 points, and I'm sorry that I
No,
threw them all in
that's
there for you, Mark.
That's great. So I'm going to ask each of our doctors to address one of them. Tanika, how do you deal with the situation where patients don't want to know, or families don't want to, parents don't want to explore when you see something amiss?
yeah, I think that's very challenging. And I always tell them that my job is to make sure that you are as well informed as you could be. And I keep telling them that, knowledge is power. I'm very respectful of families' wish. Especially if it's a condition that's have later onset, and they really are adamant that they don't want to know, that's fine. But to relook at that from time to time. At the same token, I also want to be very supportive of my patient. So typically, it's a young adult or a middle-aged person, and she or he knows that her siblings are at risk, or parents are at risk, and try to be helpful to the patient by saying that I'm glad you're taking care of yourself, and there's other things that you can do, but you can't control their life because there is a guilt that's associated with this. Having the knowledge, and here I am getting care, but I'm worried and about my family, and I do care for them. But I also give them an example. It's like, well, they drink and they drive, or they don't exercise, and you can't have any control. So sometimes you just have to kind of let go. But I have always been very supportive of the patient and tell them that they're not a geneticist, they're not a genetic counselor. So thanks.
Yes, so it's really important to keep the long view in mind, because if you are too hard or push too far, you might alienate them and they're not going to come back. So, I agree with that approach. Michelle, back to the primary care provider. You're caring for some pretty intensive patients. What do you see as the role? Like, how do you interact with the primary care provider?
Yeah, I mean, I think primary care providers are under a level of stress that they've never been in under their life. And, I think historically primary care doctors did all the stuff that we're talking about. They took care of patients, they coordinated care. And I think a couple of things have happened. One is they are now seeing patients every 15, 20 minutes, and the patients are getting sicker and more complicated. And there's just no bandwidth for them to do it. And I think they're trying very hard, and I think they can't do it. And again, I don't really know, like, I think about Christina, who doesn't really have just a straightforward genetic disease where we have like one gene, one problem, where we know what to do, and we have people, as with more than one genetic problem. We have people we know have a genetic problem, we can't prove it, and we're kind of making stuff up as we go along here. And I don't mean that in a bad way. I mean, in the much as we can help somebody without having all the pieces. I think the other problem for primary care doctors is that as you start getting into rarer and rarer and more complicated diseases, they just can't keep track of everything, right? Like, they can't know everything about, whether it's an adult or not. Even if it's an adult, they got to keep track of, or for pediatricians, that matter. There's all this screening they have to do, and screening if there's guns in the house, or did they get their colonoscopy screening? And is their hypertension under control? Are they getting enough food in the house? I mean, like we have just dumped all this stuff on primary care doctors. Figure out if people are safe, mentally healthy, they got all their screening, all their major problems are done, and then, okay, by the way, you also become an expert in rare disease. And it's just not realistic, particularly as we get more and more, as medicine is more and more complex. And I'm going to say this, going to boomerang back to the original question of what did COVID show us that we can't do? And COVID has shown us that we are overstretched in how we take care of patients. We're asking doctors, nurses to take care of too many patients under too many bad things. And then what ends up happening then, it keeps going down. So the patients now are, I do think lots of patients are taking care of themselves, right? They are coordinating their own care. They are doing stuff like that because we don't have good resources to take care of them. We're not giving doctors, nurses enough time. We're not giving the people, I mean, it'd be great if every complex patient had a care coordinating nurse. I mean, this would be a great role for nurses, APRNs and stuff like that, to kind of learn some of these things and have a limited load where they really could help that. And that doesn't even get into the last part of this, what I'm going to call within that primary care, is that just accessing resources. I think Shanika brought up something which, when she said it was like, I thought, why didn't I think about that? But we can't even get people sometimes the basic care they need because there's not enough providers. We're in a home health care shortage. We're in a home health thing. Under COVID, people wouldn't even go into the houses and do stuff. It's like we are in a system that is so broken at this point. I think primary care doctors are just doing the best they can to try to do the best they can by their patients with very limited resources and very limited time. And if we want to fix this problem, we have to fix it on a global level of how are we going to care for our patients, our families, our communities, and give the time and resources necessary. That's not, I know that may not be the most satisfying answer, but it really needs to be fixed on a bigger level.
Absolutely. It's a complex healthcare system. You have a complex patient sitting in front of you. Christine, you have a person comes up to you for advice. They have a multi-system illness. What would you advise them in terms of resources that they could access that would help their healthcare? Christine, do you want to?
Sure. So I was kind of left into the healthcare system on my own. My mom was an immigrant. I was a kid when I got sick. There were 4 other kids at home, so it was very difficult to manage. Now, I got a diagnosis at one point for lupus, which kind of put a stop at everything, right? Because now everything that I was experiencing now could be attributed to this. And so one of the biggest things about me was that I wasn't going to accept the answers that I was given.
Mhm.
And so I knew that there was something going on. And even if this person couldn't see it, I knew that there was something there. And I know that sometimes patients exaggerate and, all of these things that make us doubt some things that they did. But my biggest piece of advice to patients is always, you are the one who knows your body best. And one of my physicians recently told me, he said, you have the body of an athlete. Not that I'm an athlete, but he said that you are very in tune with how your body changes, even temperature fluctuations, I am aware of. And I think one of the things that people have to do is also, as a patient, be in tune with yourself. Really know what you're experiencing, be able to keep track of things that you're going through and conversations, right? I found one of my rare conditions was because I was talking to somebody in another country about symptoms that I was experiencing. And I was able to get some input from there and then was able to push forward in demanding other tests. And so I think as a patient, we also have to take that active role and not expect everyone to just fix us, but really kind of look at what is our role here? What can we do to help this process move along? Even as far as collecting data, right? I always ask my doctors, what is it that you need from me? Like, if you want my blood pressure taken, great. What time do you want me to take it? What do I need to be doing? Things like that, things that we as patients don't really think about are things that we also have to now kind of incorporate into more of a proactive kind of healthcare system rather than reactive.
So, so using yourself as your own resource and upgrading that, perfecting that.
And looking around, right? I think too, we a lot of us go to Facebook and social media platforms for things. I tell patients all the time, LinkedIn is my source of information, right? Because you have the researchers, the scientists, you're seeing the articles that are published, but you're not getting all of the opinions and op-ed that you might get on other sites, right? I also recommend Google Scholar for people, right? They search Google, but do you search Google Scholar? So tiny little things, right, that you can do for yourself to kind of improve your education and your awareness around these things, and then to bring that as a collaborative, right? My doctors appreciate the fact I just brought them the name of a rare condition that I think might be mine. They appreciated that. They did research. The researcher that's assigned to my case just sent me 10 articles on it. And so I think it's that idea of really collaborating together and how can we help each other, not me just going in and saying, these are my symptoms, help me. Right. But really taking an active role in your health and doing some of the things that you need to be doing or not doing some of the things that you are doing. And we have to take a little bit of responsibility for ourselves.
Being the educated patient.
Yeah. Being an educated patient.
Doctors, what do you suggest? Give me an example of a resource that you might suggest that might help patients navigate their way, help themselves. Michelle?
I think that is very individualized. And so when we, I think there's different ones depending on where you're at. I actually don't love, I love and hate Facebook at the same time. Okay. I love the fact that Facebook allows families to connect with each other. I think it's been a great way for resource building in rare diseases for families to get together and be able to do actionable things. On the other hand, there's a lot of stuff on Facebook that is just outright scary and not so positive or accurate that oftentimes scares families to death that I would not want to do it. So I think I kind of look at this as a 3-pronged approach, when I'm talking and I'm counseling families. One is I like to give them sources of information on the disease. And honestly, if for people who are diagnosed, people who aren't diagnosed, we try to, try to use, kind of give them some different kinds of resources. It's a lot more struggle, but, so they're getting a balanced opinion. And I actually feel like, I always tell them in rare diseases, not everything is published. And a lot of the spectrum is not published. And a lot of times only the more severe cases are published. There's things in the publication that we no longer believe. So that's the first thing that says, is that ultimately your care team should be your resource. If you read stuff that's scary or something, come talk to me. I try to really couch the complexity and the variability with any condition. So I think that's number one, is we should be their primary things that we just have the experience of doing. We've been doing it for a long time. But knowledge is power, and I want my families to know as much as they can. So I try to give them good resources in addition to that. I think patient support groups that are well organized are another really, really great resource for it. So that's good there. And then also, I look a lot to like social work and some of the social things in the community, because these families need more support. And I think that's one of the pieces, a lot of stuff on educating the family and this and that, and what form you need to fill out to get your formula, whatever else. But then also just like mental health, social support. You're not alone. There's other people you can talk to and kind of do there. So I think those are there, particularly for people who are diagnosed. For the undiagnosed patients is the one I really struggle with it, right? Where you clearly, a patient has a complex disease. They're going from doctor to doctor. They feel like nobody's taking ownership. Nobody's taking ownership of them. Nobody can really tell them what to do. I think those are the hardest ones. So, I think in those cases, since there's not published research, there may not be so there are some support groups and not a lot. We kind of have to be their cornerstone, and we kind of have to be that anchor that helps them kind of navigate it through. And I think I tell them, if you see something you think is what's going on, email it. Now we do everything epic. My chart message it to me so we can help you work together to either get those resources or to the researchers, get to study trials, or if I can do testing or additional evaluation here, we can. And I have absolutely throughout my career had patients send me stuff and I'm like, I think you're right. We've made diagnosis that way. So I do think it's kind of a collaborative thing, but I think in the undiagnosed complex rare patient, at the end of the day, we have to be the main resource.
Absolutely. Shanika, do you have any innovative resources that you use or that you can suggest?
Yeah, so just add to what Michelle just said is to make sure that the family know about resources in the state, especially through the school system, to get them support. That's, not only social worker, and physical therapy, but, how do we navigate through the school system? Because that's actually where a lot of resources happens. And the other one that I go to a lot is prepare the family for transitioning out of the childhood into young adult, especially young adult with intellectual disability. And who's going to be the legal guardian, who's going to make the medical decision, because once you turn 18 or 21, it's kind of a big world for them to navigate. Before at 17 and 364 days, you can still talk to the parents. And when the patient turned 18, it's like the parents can't look at the chart, and they still need the support. So sort of between that age to really talk about what parents need to think about.
No, and no, absolutely. And I would say, Shanika and Michelle, you are both pediatricians, so you operate from within that world. And I would say the things that you mentioned about school has a counterpart workplace for the adult population. And, that has to be considered as well. So I would just again invite attendees in the audience to submit questions in the Q&A, and I will pose them to our panelists. Michelle,
And
you
Mark,
mentioned, yes.
Oh, I was just going to make one comment. I know that, social media
Sure.
is one of these platforms that all of us as patients, we go to share stories, but there are those real concerns, right? Of privacy and data security and even surveillance capitalism that's happening. And so I just wanted to make note that there is a group of patients who are working to really build a better patient platform. And so Light Collective is an organization that is really looking at establishing a safe and fair online platforms for patients to be able to share their experiences without third parties interfering and coming in. And so I think that, I think social media is one of those huge resources. Like I said, I found one of my conditions from a patient on the other side of the world, and we need that collaboration. We just need it done in a safer way.
Christine, would you mind putting the name in the chat box?
Sure.
So that we have an access to that.
Yeah.
So Michelle, you mentioned the acronym RVU, which stands for Relative Value Units, which is a method of assigning compensation for the services that doctors provide. How have, so Janique and Michelle, how much are your RVU goals to generate revenue influencing your care? Janika, do you want to start?
Sure, you got me as the division director.
Okay, you can go anonymous for this.
So I think fortunately, I have a department that's very supportive. My department realized that in order for us to be able to provide quality care, we cannot just count the beans and meet this expectation. So a lot of our work really, for example, our genetic clinic is embedded in the Children Neurodevelopment Center. So we work with neurology and developmental pediatrician, and sort of try to the department and the hospital try to have them realize that as we work as a unit, therefore it's much more complex, it takes longer time. And do I have to follow the RVU? Definitely, that is pretty standard. I think amongst us geneticists, every department chair has access for division specific, which has been helpful. So I think that we have used that. How do RVU affect our care? I don't think we prioritize based on the RVU, but we also make sure that whatever documentation that we can enhance and meet the criteria and document, we want to get credit for what we do. We don't want to throw away our effort either. That's not what we're here for. The lawyers, they bill you by minute, right? The physicians, we don't do that, but there are part of the system that allow you to get credit for the work you do. And balancing that, I do think it's a hard act, but that's part of what I do as division director, is to make sure that we have that balance.
Good, thank you. Michelle, what do you have to say?
Yeah, I mean, so I would agree, Shanika. And again, I'm also in an administrative role where I do have to look at my RVUs and other people's RVUs and how we're maximizing them, which is really painful. I think the way we definitely have issues where if we don't meet certain levels, the RVUs are based on the 50th percentile of what is reported through the American Hospital Association. So they're normalized data for other academic centers throughout the country. It is influencing the number of patients we're seeing, I think, and I think how we're billing and what things I don't think what we're prioritizing is the wrong word to say, but I think it definitely affects how many clinic sessions people are doing, how many patients they're seeing, how they're documenting, and also even I think in the consult service too, how we're utilizing and maximizing that. I think the biggest thing, I think all of us are kind of like, again, we're still focused on patient care. We're still focused on doing the best. I don't think that has changed. What I think it's contributing to is physician burnout. And I think that's something it's frequently not talked about, but survey after survey is coming and showing 65-70% of physicians are burnt out, are having, and the number of physicians having serious mental health issues that they're continuing to work through. And we talk a lot about patients, and I think that's important. But I also think, there's that whole thing, if you're not caring for yourself, how are you really caring for other people? And so, I think you're seeing a difference in younger doctors coming out. I mean, I trained a number of years ago. I'm in practice. I came through that, work 120 hours a week, don't sleep, and you're fine, and keep going. And that is the mentality. There's a lot of bravado. You're not seeing that in the newer generations. And I'm hoping that's going to lead to better things, because I think it's one of the reasons we have a doctor shortage is doctors and nurses. It's not just doctors, it's nurses, it's physical therapists, it's all these things, because people are leaving. And what I think people don't talk about, these RVUs things and the stress of COVID and the complexities, is that there's just not going to be anybody to take care of the patients anymore. And that is why we're seeing them out, and why we're seeing people not go into certain things and moving on to other jobs. So I would say the biggest thing for RVU is physician burnout, a loss of physicians, nurses, healthcare providers. They're sick of being on this thing. I mean, on the treadmill of being pushed harder and harder. And even I think going back to why are primary care doctors seeing more? Let's get rid of genetics, right? Because genetics, I agree, is more protected. Primary care doctors are seeing patients every 15-20 minutes because of their RVU goals, and is why they don't have time to coordinate care for patients.
Well, big sigh. So Christine, you have thought a lot about advocacy, and probably thought a lot about what makes a good provider for you. So can you advise us on what do you look for in a provider to get a sense of how he or she is going to serve you well?
Yeah. So I hate to say it, but I kind of go by vibes.
Well,
I think when you walk into a room,
right.
right, the energy that a person emits and just how they look at me, right? I think even just how I'm approached in the office also says a lot. I have two physicians who have vented to me in the past about how they're overworked and they're hitting depression themselves. And I think one of the things that's really important is being able to find a physician that you can have a relationship with. I think that's one of the biggest key points, and one of the reasons why I've been able to go further than a lot of other people is because I've established a relationship with my physicians where I want to help them and they want to help me. And so we've come to understandings together and how we communicate. And I think I've had physicians where, when I was a kid, I had an Indian doctor who I thought was the most horrible person in the world because I thought she was mean. And all she was doing, she was just a business type person, right? And so I think going into it and understanding someone's culture, understanding how they work is important. Some of the best physicians I have, my cardiologist, he's the head of cardiology at Stanford. First time I saw him, he closed his computer. He said, Christine, I started looking through your charts and it's a mess. And he said, I'm going to close this. He said, I hope you don't mind. It's not standard practice. He said, but I want to hear what's going on. And so that to me was the key, right? The people that have that other side of empathy that can put aside, and I know there's not a lot of time, right? He was head of cardiology, so it's a little easier for him to squeeze in some extra time. But I think those relationships are important. The fact that I even know my doctors are struggling with depression is something that most of patients don't know, right? And so how do we build a better relationship where we can talk to each other about things and really approach each other kind of as equals in this, right? Because you're going to need me to find out what's wrong with me, and I'm going to need you. And so how do we really build an effective communication? And I think it is, you kind of got to go with who you get along with, who you feel welcome with, and who you work best with. So I think it's a personal decision, right? But one that you have to take very, very seriously. And also for patients to know that if you happen to come across a physician that you don't quite gel with, it's okay to find a new one. It's okay to go out and find what's best for you, and no one's going to be offended. Nobody's going to be hurt. but really keeping it that, I guess, professional and yet friendly relationship at the same time, if that's possible.
Yeah, sure. You know, one thing I often mention to patients and families when I deliver a new diagnosis and we talk about the details of that diagnosis and what they may need and they're going to require. And when they come back and they have this list of expectations, and I often encourage them, speak to your primary care provider, tell him or her what you need from them. Some doctors will respond, oh no, no. I have too big a practice. I'm really just here for vaccinations and ear infections. And for the little things I can refer you out, but I really can't get involved. If that doctor tells you that, he or she is doing you a favor, because there isn't going to be a passive aggressive relationship where you're going to be disappointed and they're going to feel like they're not delivering. It's okay to interview the doctor. And if they're honest about it, that's great. Saves you time. Go find somebody else to do the same thing. A doctor who feels comfortable with complex disease. So anyway, this has been terrific. I really appreciate the perspectives that you have all shared with us. Some very valuable ideas, concerns, and there is hope, given how the system did respond in many ways to COVID. Hopefully that will set a tone for going forward. So at this point, I think this is done. And Nicole, do you want to?
Yes, I just wanted to say thank you to Dr. Corson for moderating this talk, and thank you to our great panelists, Michelle, Shanika, and Christine, for your thoughtful and meaningful conversation. I want to thank all the attendees for joining us and listening in, as well as our sponsors. We will be sending out a survey to everyone at the end of this talk as well. So if you wouldn't mind filling that out, we'd appreciate it. And we also have our continuing our conference next Thursday, October 13th, as well as October 20th and 27th. We have some more great talks coming up. So we hope you all join us, and we're looking forward to it. Thank you, everyone.
Thank you.
Thanks for having us. It was fun.
Great. Have a good night.